Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Acadia Pharmaceuticals, Inc.
Hi, and welcome to this live discussion titled Case Challenges in Rett Syndrome, Reducing the Time to Genetic Testing, Diagnosis, and Treatment. I'm your moderator, Dallas Armstrong. I'm an assistant professor at the University of Texas Southwestern in Dallas, Texas. Joining me, I have two colleagues that I'm pleased to introduce. I have Dr. Carrie Fu, who is the medical director of the Rett Center at Vanderbilt University Medical Center in Nashville, Tennessee. And I have Dr. Steven Skinner, who is the medical director at Greenwood Genetic Center in Greenwood, South Carolina. And we will also be hearing from Ms. Liz Adams, who is the caregiver of a Rett syndrome. In this program, we will start with a patient journey video of a caregiver for a patient with Rett syndrome. We'll give a brief review of the pathophysiology, symptoms, and epidemiology of Rett syndrome. We'll discuss best practices and the use of genetic testing in the diagnosis of Rett syndrome. And lastly, we'll provide a summary of the guidance for managing specific symptoms of Rett syndrome, currently approved, and investigational therapies. And now we'll hear from the caregiver of a person with Rett syndrome.
Hi, I'm Elizabeth Adams. My daughter, who has Rett syndrome, is almost 10 years old. My daughter was born in November 2015. Around 2016, we really started noticing that she was not reaching milestones. At that point, when we mentioned it to pediatricians, they truly didn't believe us. It was another probably 6 months at around 18 months old. We started noticing that a regression had happened. The one word that she had was completely gone. She was no longer sitting up. After fighting with pediatricians for a while, we finally got into genetics, where after about another 2 years, we finally received a diagnosis of Rett syndrome. Since then, we have learned to navigate lots of doctor's appointments, lots of therapy appointments, Medicaid, all the crazy things you've never really thought about. For her day-to-day, she wakes up bright and early in the morning around 6 or 7. I get her ready. I change her diaper. I pull up her hair. We get her in her chair. We take her to school 5 days a week at a special needs school. After that, she comes home. She does her in-home therapies 3 days a week. She does have a G-tube, so she does not ingest any liquids. Then in the evenings, we usually eat some dinner together with the family. At night at about 8 o'clock, that's when she starts really winding down, and then she's usually asleep by about 10 o'clock. So yeah, talking about some of the harder aspects of Rett syndrome, seizures. So as she sleeps, she has a camera on her because her seizures do typically start at night when we don't have eyes on her. You can't always hear the seizures. Her seizures often are silent. So the camera will wake me up if needed. Some of her symptoms, she does a lot of breath holding. So we typically keep a hand on her a lot and just massage her chest just to kind of remind her, hey, take a deep breath, all is good. She doesn't do a lot of hand wringing. She does a little bit, but hers is mostly biting. So she has wounds all the time on her index fingers. She does have pretty progressive scoliosis at this point. We're waiting on puberty to hit, and then she will likely be having surgery on her spine. She is completely nonverbal. She does make some noises, but there's absolutely no words. She uses an eye gaze talker. That's absolutely amazing. This eye gaze sits on the front of her wheelchair. and she looks at it and it speaks for her. And she is quite funny on it. She's able to tell us if something hurt. She can't be like, my head's hurting or my arm's hurting. I would really like to convey doctors, clinicians to really try to listen to parents. When you have a parent that's standing there telling you there's something off, there's something wrong, please try to give them the support that they need. You're out there on an island by yourself when something crazy like this starts happening, and you have your pediatrician almost tell you that you're being crazy and you're being dramatic. It was insanely difficult.
With that in mind, the sense of all the body systems affected by Rett syndrome, let's step back and think about where this journey began, where the medical community started to recognize a unique pattern of symptoms. So briefly, Dr. Rett published the first report in '66. Dr. Hagberg simultaneously was collecting data and then was able to publish his study in '83 and gave credit to Dr. Rett, which is one of the joys of this syndrome as well, giving credit where it's due, and that's a beautiful story as well. The prevalence you can see here, median age of diagnosis about 3 years, and the more we collectively as a medical community know, the earlier we move that. Many individuals live a full, robust life, and I think that's really important for people to understand and know. And this is associated with spontaneous pathogenic variants in the MECP2 gene, which is on the X chromosome. And we're going to talk a lot about those genetics a little bit later in the talk. So thinking about classic Rett syndrome, we know there's progressive neurodevelopmental disorder, primarily affecting girls, although boys are also affected. Developmental slowing and a plateau phase. There's a regression and a loss of skills. And there's this pseudo-stationary phase where regression slows and then stops, and then this late motor deterioration phase. And there's really increasing rigidity, and spasticity becomes a really important part of the syndrome to be managed. Here we have the understanding that the MECP2 gene was actually causative for the majority of people who fell within the classic Rett syndrome umbrella. And this is Dr. Amir's paper from Dr. Zogby's lab. And then thinking about the MECP2 gene, it's important to think about the protein encoded by this gene and all the different functions that it subserves, that it's involved in transcriptional regulation and several aspects of gene regulation. And that also helps us show all the different body systems that are affected by Rett syndrome. We're going to get even further into the genetics of Rett syndrome, and who better to talk about that than Dr. Skinner. And we're thankful to have you here to talk through this part of the disorder with us today. Thank you, Dr. Skinner.
Thank you, Dr. Armstrong. And even though I'm going to be talking about the use of genetic testing in the diagnosis of Rett syndrome, I'm going to start by saying that genetic testing and the detection of a variant in MECP2 is not required to make the diagnosis of Rett syndrome. Rett syndrome is still considered a clinical diagnosis. And I say this because patients may have a clinical diagnosis of Rett syndrome but not have a detectable variant in MECP2. This doesn't happen often, but in a little less than 5% of cases. And conversely, patients can have a variant in MECP2 but not have clinical diagnosis of Rett syndrome. So it's important to understand the clinical diagnostic criteria and how to utilize those along with genetic testing to best categorize patients and manage patients. Clinical criteria for Rett syndrome first developed in 1984 by Dr. Hagberg and others. These criteria have been revised several times, and most recently in 2010. And I think the importance of using these criteria is really how to use them in context with the variants to categorize patients carefully. And I will say the hallmark of all the criteria is that there is a period of regression followed by recovery or stabilization that is needed for a diagnosis of either typical or atypical Rett syndrome. So for classic or typical Rett syndrome, again, there's this period of normal development for usually the first 6 months of life or so, followed by a period of regression, and then there's four main criteria: partial or complete loss of hand skills, spoken language, also some gait abnormalities, and then the stereotypic hand movements that may be the classic hand washing or hand wringing, but can be other types of repetitive hand movements. I will point out that the loss or partial loss of hand skills and spoken language can be subtle, particularly if the regression occurs at a young age. So it may be loss of babbling or cooing and not actual spoken words if the regression happens early in the clinical course. But I think, again, the thing to remember is this period of regression is required for a classic or typical diagnosis of Rett syndrome. And then also for atypical or variant Rett syndrome, that period of a regression is also required to meet clinical criteria for Rett syndrome. However, in atypical or variant Rett syndrome, instead of having all four of the main criteria, you have to have two or more of the main criteria: the loss of hand use, the loss of spoken language, the abnormalities of gait, as well as the repetitive hand movements. And in the atypical criteria, we see the supportive criteria that are helpful in making the diagnosis. Now, these are 11 criteria. To make a diagnosis of atypical Rett syndrome, you need to have 5 or more. I will point out that these are not specific or unique to Rett syndrome. These can be seen in a variety of neurodevelopmental conditions. So it's really taking the context of the period of normal development, regression, the main criteria and the supportive criteria that helps determine whether a patient meets clinical criteria or for classic Rett or atypical Rett syndrome. Having said all that, and saying that the role of genetics is not a prerequisite for making a diagnosis of Rett syndrome, I think it is very important and critical, and one, in confirming that clinical diagnosis, to have that molecular confirmation, both for the clinician's comfort level, but also for the families to know that there is an objective test that can point to that clinical diagnosis. And hopefully, knowing that specific variant that's in the MECP2 gene, we might start to talk about genotype-phenotype correlations, though I will point out there are not hard, fast genotype-phenotype correlations that we can make precise predictions of. And then, very important to point out that genetic testing is required to be eligible for clinical trials, and with 2 gene therapy trials now in place, having that genetic testing is going to be a prerequisite to get into those clinical trials as well as future clinical trials. So just a little bit about genetic testing. We are seeing very few patients come in for single gene testing like we used to in the past. Many patients are now coming in for some type of next generation sequencing, whether it be multi-gene panels, whole exome sequencing, or whole genome sequencing. The one caveat I just want to point out is that need to make sure that the technology used by the lab that you send the testing will pick up not just the point mutations, the small deletions or insertions, but also large deletions that might involve exon 3 or 4, exons 3 and 4 in the MECP2 gene. This accounts for about 5 to 7% of patients with Rett syndrome and can be missed by traditional Sanger sequencing and possibly even by whole exome sequencing, depending on the technology used by the laboratory. So make sure you have good confirmation from the lab that you utilize that they're using technologies that will detect not just the point mutations and small deletions, but also the larger deletions. And I will also point out that now that these next generation comprehensive testing is being used earlier in the evaluation, we're seeing the interesting phenomenon where sometimes we get an abnormal variant in MECP2 reported before we actually see the clinical criteria play out. And that really causes challenging counseling sessions to talk about the future expected regression, but not knowing when that's going to happen and how severe it's going to be and what's going to come back. So I'll just point that out as something that we're starting to see as more and more patients have comprehensive testing earlier in their evaluation. But I will say that with classic Rett syndrome, typical Rett syndrome, we anticipate to find a variant MECP2 in over 95% of the cases. And atypical, that percentage yields goes down significantly, about 75% of cases. I'll also point out that conditions that used to be considered variants of Rett, such as the early seizure variant, is now pretty much known to be associated with CDKL5, a different gene, and I think a different condition. And the congenital variant of Rett syndrome in the past is now being associated with FOXG1 condition, which is, again, a different gene. And we are now seeing over 80 different genes associated with Rett-like conditions. So as we do next generation sequencing, we're going to see better delineation of the specific molecular cause of many of these neurodevelopmental conditions. So again, just interpretation of genetic testing, as we've kind of made the point, you will find variants in MECP2 in association with the classic Rett syndrome, atypical Rett syndrome, and what we call MECP2 related disorders. I think the clinical criteria are helpful to help put patients in the right category so that you can help provide the appropriate counseling and guidance for patients and families. Again, majority of these are de novo variants, so very low recurrence risk, but the testing and knowing the genetic variant can help with appropriate family testing if needed. And then, just as has already been alluded to, early diagnosis is critical. It certainly shortens the diagnostic odyssey, which answers that first question for patients and their families: what is causing whatever problems are facing their child? Having that answer then empowers the family to make sure they're seeing the right specialists, going to the right centers, getting involved with the right literature reading, again, the right opportunities for clinical trials and natural history studies, allows for appropriate genetic counseling. And then for appropriate medical management and therapies, there are clinical care guidelines for primary care physicians. So having that diagnosis of Rett syndrome and appropriately made is critical to make sure appropriate management. And then now, with 2 gene therapy trials in place, other clinical trials beginning to develop, it's important to have that early diagnosis both clinically and molecularly through genetic testing.
So true. Thank you so much for all of those points, Dr. Skinner. And also, I think all 3 of us, when we think about the things families gain from that genetic diagnosis, there's also that sense of, falling under that bullet point of empowering the family is connecting the family to others. When we go to those conferences and we see all the little girls with Rett and all those families together, I mean, that's such an important part of diagnosis,
I agree.
For sure.
Yeah. Thank you so much. Dr. Fu, thank you for talking about the importance of team-based care in Rett syndrome and how collaborative people have to be as they care for these individuals.
Yes, thank you very much, Dr. Armstrong and Dr. Skinner. So now we've made a diagnosis, and so now what? What's next? How do we deliver optimal care to these children recently diagnosed with Rett syndrome? And I think, like so many things in life, I think this is where, the term "it really takes a village" comes into play. And so, after we've made that diagnosis, it's very important to remember that, nominally, while, we are dealing with a neurological disorder, Rett syndrome very much over the course of a child's lifespan will, as they become an adult, is going to impact multiple other organ systems. And so it is very much incumbent on families to identify, a care provider that's very comfortable dealing with complex disorders and that can help coordinate care within multiple disciplines, because frequently, not only will a child with Rett syndrome need to see a neurologist, they may need to see a gastroenterologist, they may need to see an orthopedic specialist. They definitely will be seeing multiple different therapists, speech therapists, physical therapists, occupational therapists. As you saw from the caregiver video, there is a lot that can be done with AAC devices to help these children communicate. And so all of that care really needs to be coordinated in order to optimize the health, well-being, and quality of life for not just the patient, but their families. So until recently, optimal care in Rett was very much just very much symptom directed, right? Because that's kind of what we had. There was nothing specifically approved that was indicated for Rett syndrome. And so we managed each of the individual domains of symptoms according to what they are. So for the epilepsy, it's the conventional anti-seizure medications that are used in epilepsy in the general population also applies to children with Rett syndrome, but nothing specific. Movement disorders, they're frequently confronted with a lot of dystonias, paroxysmal dyskinesias, and so, but all of those, we borrow from what's learned from other movement disorders and apply it in Rett syndrome. And you kind of go on down the line. Gastroenterology, they frequently will have constipation, issues with gastroesophageal reflux, again, frequently needing to be referred to a gastroenterologist. But again, the treatments that are deployed are symptomatic. Now, that changed around last, I guess it's been 2 years now, March of 2023, we had the first FDA-approved medication specific for Rett syndrome. So we'll talk a little bit about now the targeted pharmacological treatment for Rett syndrome, which is this molecule called trofinetide. So it's an analog of an endogenous compound. So this is the terminal tripeptide of insulin-like growth factor 1. So it's a natural cleavage product, which they've modified to increase bioavailability so that it's orally bioavailable. And in preclinical models, mouse models of Rett syndrome, this trofinetide was found to reverse the Rett-like deficits in these mice, improve survival, and also had some relevant neurobiological, histological changes in terms of synaptic morphology and function. So based on that preclinical data, there were human trials performed. There were 2 phase 2 studies, one in older individuals with Rett syndrome and one with younger, that had signals of efficacy, which finally paved the way to a phase 3 pivotal study that was relatively large, enrolled about 150 people. It was a randomized controlled trial where they were able to demonstrate that trofinetide had small but clinically meaningful improvements over placebo in the core features, core symptoms of Rett syndrome. Now, unfortunately, not everything was rosy. There was a high rate of adverse events, and mostly in the form of gastrointestinal side effects, diarrhea and vomiting, which sometimes did limit the effectiveness, just because that was one of the main reasons for having to discontinue, was these side effects, which are manageable though. So this phase 3 trial though is what ended up leading to its approval by the FDA in March of 2023. And thus far, it is the only FDA approved treatment specifically for Rett syndrome. Again, this trofinetide is available as an oral solution for individuals with Rett syndrome greater than or equal of 2 years of age, so across the lifespan. It's twice-a-day dosing that's weight-based. It can be given orally or through a gastrostomy tube. Now, people with a J tube can also receive it, but needs to go through the G port, so it has to go through into the stomach. Again, there were relatively high rates of diarrhea, vomiting, and other things related to the palatability and the gastric tolerability. So people sometimes lost weight if they stopped eating because they were having a lot of vomiting. But again, we'll talk a little bit more about ways to kind of mitigate that in the next slide. There's been a lot of strategizing on how to improve the tolerability and managing the diarrhea, and we found that it's helpful to have some sort of baseline bowel activity documentation, so we kind of know what it's like preceding and then how to manage things ongoing. But right before you start it, it's a good idea to reduce any sort of medications they were taking for constipation. We're going to limit any medications that can increase transit speed through the gastrointestinal tract, and try to shy away from any other liquid medications that contain sugar alcohols, and then switching to tablet forms of medications whenever possible. And also we found that starting a psyllium fiber supplement can be helpful for improving the consistency of the stool and normalizing it, making it more of a paste consistency instead of watery. And if children do develop diarrhea on trofinetide, it's been determined that oral loperamide can also be something that is safely used and can kind of limit the frequency of the stools. So sometimes it does require referral to gastroenterology to better manage, but we have found that, again, with management strategies such as that, the majority of individuals can end up staying on the medication long term. So what about for the future? So this is, again, just the first, and while very encouraging, it is still does have its limitations. And so there has been a lot of research that's been done looking at methods of true disease modifications, and this has kind of been predicated upon the successful reversal in a mouse model. It was first described in 2007. This was a genetic mouse model where they were able to reverse active deficits at an adult age, reverse those symptoms after they turned the gene back on in this mouse model. And so it was, again, very encouraging and very exciting. And so there's been a lot of hope over the last decade and a half for additional meaningful therapy development. So in addition to gene therapies, it also involve other pharmaceutical interventions, both targeting the MECP2 gene itself and then also other pathways downstream of MECP2. So currently, as Dr. Skinner alluded to, there are two gene therapies, AAV9 based gene therapies that are actively enrolling, looking at both younger cohorts and then an older population of children with Rett syndrome, looking at the safety and efficacy of these gene therapies. One of them is intrathecally delivered, the other is intraventricularly delivered, so very different delivery methods, and then slight differences in the nature of the transgene that's being delivered. But again, the hope is that this will just be the next step, and there will be many other avenues in the future that we're going to be pursuing. And of course, with the big challenges of optimizing biodistribution and then avoiding overexpression of MECP2, which is important to remember as we're talking about gene therapies. Well, as a conclusion slide here, we've talked a lot about Rett. So we know that it's a permanent progressive neurodevelopmental condition that impairs gross motor, fine motor, communication skills, and then will impact multiple organ systems throughout a child's lifespan. The diagnosis of Rett syndrome at its core is clinical and relies on specific clinical diagnostic criteria, and that can be supported by the genetic identification of a MECP2 mutation. The treatment currently focuses on managing the symptoms, and then, but then recently with the approval of trofinetide as the only FDA-approved treatment for Rett. But then there are currently ongoing trials looking at other genetic approaches to disease modification, also looking at dysregulated pathways. I appreciate everybody's attention.
What a beautiful summary of such complex therapeutics. Thank you so much, Dr. Fu. That was so fast and so full, and thank you very much. I really enjoyed it. It has been really fun to go through this with you, and thank you to all our attendees for your interest in this important and timely topic. Thanks so much.
Thank you.
Thank you so much.